Okay, we can go ahead and get started. Good afternoon, everyone. Thank you so much for being here. Welcome to our fourth Brown Bag Research Conversation Series. We're thrilled that you can all join us this afternoon. My name is Joanna Hossack, and I'm a specialist in the Institute of Urban and Regional Development. I'm joined today by my co-host, Laura Herrera, who is a financial analyst and community-based participatory researcher who's been working in the cannabis community and industry since 2009. I'm so excited that she could be here today. For those of you that don't know, I'll provide a little bit of background about the Cannabis Research Center. We've been around since 2017, and since then, we've been addressing issues surrounding cannabis agriculture, the environment, local policy, and just big picture industry issues. I invite you to check out our website, crc.berkeley.edu, to dive into our resources page. You can check out all of our published research and look at our past brown bags and webinars. I also invite you to sign up for our newsletter, which you can register for on our website, and I can also include a link in the chat. And we also please follow us on our social media, our Instagram and Twitter. So today we're very excited for our fourth episode of our California Researcher Conversation series, where we interview different California researchers, particularly looking at their DCC-funded projects, to allow the audience to ask questions, ask a lot more questions in depth, and just dive into some of these topics. So today we are very thrilled and honored to invite and have here today Dr. Ziva Cooper. She is the director of the UCLA Center for Cannabis and Cannabinoids. In 2023, UCLA received, I believe, 6 grants from the DCC, totaling $9.5 million, which supports a research on a wide variety of topics, from potency and the effects of cannabis products to the financial health of California's cannabis market. Dr. Cooper is a PI on several of those DCC grants, examining topics including a controlled human drug administration study to compare the adverse effects of smoked cannabis and inhaled concentrates, DABs, a study exploring whether CBD may reduce the adverse impacts of THC, and a study assessing the feasibility and consequences of implementing a cannabis potency tax, among much other research. So we're very excited to hear from her today about a variety of topics. Before we jump in, I just want to let you know about the format of the meeting. We'll start with an introduction of the guest speaker. We'll move into a conversation of some prepared questions. At the end, we'll give about 20 minutes for the audience to ask Q&A. So as we go through this discussion, please put your questions into the chat or the Q&A feature, and we'll get to those at the end. And then at the very end, we'll promote some of our upcoming CRC events and opportunities to get involved. So this will end at 1 p.m. And I also want to let everyone know that this meeting is being recorded and will be posted to our website when we're after. So if you have any questions, pop them in the chat, and let's go ahead and begin. So, and then here are just some Zoom basics so that you get situated. So let's start with just an introduction. Ziva, could you please tell us about your work at the UCLA Center for Cannabis and Cannabinoids?
Yeah, so I'll tell you a little bit about the center and the type of work that I specifically do, that I'm trained to do. So the center started off as an initiative in 2017, and it was geared towards bringing scholars from across campus together as, the implementation for adult use cannabis legalization was on the horizon. I was at Columbia University in New York at the time, and I was there until 2019 when I came to join the team here. And I came to join the team specifically because of my experience doing clinical work with cannabis and cannabinoids, so placebo-controlled studies. and working through the regulatory procedures involved with those types of studies. And we can talk a little bit about that. So when I came in 2019, we were still an initiative, and then we became a center probably in, trying to remember now, I guess it was 2022. And, many thanks to the Department of Cannabis Control for supporting a lot of our cross-disciplinary research back in 2020, and then again with this last round of funding. So the work that's being done at UCLA really spans the gamut of the scholars that we have on campus. So we have very basic research being done at the cellular level with, drug discovery and medications development. So we have chemists that are on the team, chemists that are looking at cannabinoids as both potential therapeutics, but also chemists who are funded by the Department of Cannabis Control to understand some of these emerging cannabinoid products that we're starting to see in dispensaries in California, but also across the states, especially those that do not have a legal cannabis market. So we have chemists working on this topic, and then we have researchers who focus on animal models of pain, substance use disorders, and so on, that are doing studies in animal models and looking at the effects in the brain. And then we have the work that I specialize in, which is kind of a bridge between the animal work and epidemiology, so large population-based studies where we're hearing that people are using a certain type of cannabis or cannabinoid product, and they're reporting that it's helpful or they're reporting that it's harmful, for example, high-potency cannabis products, and taking information that we know from the animal laboratory and putting it together and doing some of the first in-human research for some of these cannabis constituents and cannabis products. And those are called phase 1 studies that are approved by the FDA, that have to get approval from the Drug Enforcement Administration and many other different agencies. And then when you go up the ladder, to phase 2 and phase 3 research with patient populations, so the people that I study are healthy, because a lot of the products that we're looking at have never been given to a human before. And so we want to make sure that, when we're looking at them, we're dealing with a healthy population. We have studies in patient populations looking at cannabinoids as potential therapeutics in those patient populations. Some patient populations actually have cannabis use disorder, and we're looking at therapeutics that are not cannabinoids, but therapeutics that might help them with their cannabis use disorder. And then when we get out of that, basic science, health-related fields, looking at public policy, we have a lot of researchers that are involved in the public policy work. So some of which you mentioned, Joanna, you talked a little bit about our grant related to examining tax structures that can be used to reduce or impact high potency cannabis use. So that's an example of some of the policy work that we have going on, as well as other policy work. And then we have larger scale studies happening where we are looking at population level data to get a sense of, especially in the state of California, in different jurisdictions, how are people using cannabis? What are the types of cannabis products they're using? How much THC or CBD or other cannabinoids are they being exposed to, and what are the outcomes? And so, for example, we have a team of researchers who survey up to 170,000 patients a year just in the UCLA healthcare system about their cannabis use. And this type of information, although you would think it's basic and we should have been getting this information for years, decades, since 1996 at least, when California legalized medical cannabis, we are just now starting to really screen and ask people about their cannabis use in a way where we can make associations between their cannabis use and health outcomes as depicted in their electronic health records, and hospital records and so on and so forth. So we have a lot of things that are happening here. It's really exciting, and I have no doubt that I've probably left a couple out.
Wow, keeping busy, absolutely. I think what I'm really interested to hear more about is the research surrounding high potency cannabis products. Like, can flower, it used to be 20% and now we're looking at 35, like crazy high numbers for flower. But I think when you say high potency products, you're probably meaning like dabs,
Concentrate.
edibles, concentrates. So would you be able to sort of provide a definition about what you mean by a high potency cannabis product? What specific products are you studying and what are your findings?
Thank you for that question, Joanna and Laura. And I do want to clarify what we mean by potency. As a pharmacologist, we think of potency as a very strict definition related to an action of the actual chemical entity that we're talking about. So in this case, it's delta 9 THC. And when we talk about potency, we talk about how much is required to achieve a certain effect. When we're
Mhm.
talking about high potency cannabis products, we're using the word potency in a way that pharmacologists' skin kind of crawls a little bit because we're talking about the same molecule, delta 9 THC. The actual potency of delta 9 THC doesn't change. It doesn't matter. It's just a chemical. It doesn't matter if you're using it orally, smoke, vaporized. But the product itself can deliver more THC in a smaller amount of product. So if you think about it in basic terms, you have a Tylenol capsule that has 250 milligrams and a Tylenol capsule that has 500 milligrams of the active component. The active component is still the same active component, but you either need one pill or two pills to achieve the same outcome. So when we're talking about high potency, again, we're not talking about THC because the potency of THC is going to be the same no matter what. It's the actual product, how much it has to be used in order to get a certain level of THC exposure and a certain outcome. So it's really important to clarify that. And we try and do a good job of that when we write about this in the literature. Now, you brought up an interesting point about the fact that, 20% THC cannabis is a thing of the past. And now you go into dispensaries and, regularly see 35% THC cannabis. And that might be the case. But when we talk about the science and what's actually been studied, if you look at placebo-controlled studies, we actually haven't even studied that 20% THC cannabis yet. Now, the question is, the information that we have from the past, the work that we've been doing as cannabis researchers, how can it apply to what people are using right now? And so if you look at the decades of work that's been done on cannabis, and even though we always say we don't have enough research, yada, 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 there's been, even at UCLA, 50 years of work here looking at cannabis with THC compared to a placebo cannabis. And so we do know something. And one thing that we do know, a couple of things that we know, is that when you increase the amount of THC in the cannabis plant, you're going to get more intense effects. Those effects are going to vary according to who the person is. Okay, so one study that we're running right now is specifically looking at people who use cannabis occasionally, so like once a week, versus people that are using daily or near daily, so every day, and they're using pretty heavily every single day. We are giving them the same cannabis to use, different strengths of cannabis versus placebo. And what we find is that in both groups, you see that when you give them a higher strength cannabis, you get more intense effects. For example, people report feeling more intoxicated, and people report feeling that the effect is stronger as you get higher concentrations of THC in that cannabis. But of course, and as expected, when you compare the two groups, that occasional use group shows a more exaggerated effect than the heavier users. And I'll talk about an interesting finding in a second. But when you look at how much the two groups like the drug, if it's a good effect, would they want to take it again? What we see is that the lighter group, the people that are just using once a week, they'll report, kind of liking the drug, but as you get to higher doses, they report adverse experiences. For example, they report being on edge, having anxiety. And when we ask them if they'd like to take the drug again and actually give them an opportunity to self-administer that drug in the lab, they won't. They'll choose not to. But the daily users, although they're not getting as high and they don't feel as strong of an effect as the lighter users, they report liking the drug more, they want to take it again, and when given an opportunity to self-administer in the lab, they will. Another interesting feature of this, though, is that when you look at those lighter users, and you look at the THC in their blood, even though we're telling both groups of people to smoke a certain amount of this cannabis cigarette, so they're both smoking the same amount of the cannabis cigarette, the lighter users take longer to smoke it. So they take we measure 40 seconds between every puff, and we tell them exactly how to inhale. We can't tell them how deeply to inhale, which is an important feature. But the lighter users take longer to smoke it. The heavier users take shorter amount of time to inhale, so fewer puffs. And you can see that in the lighter users, their THC plasma levels are not as high as they are with the heavy users. So the heavy users are getting all the THC they can from the cannabis we have. The lighter users are what's called titrating. They're getting up to the point and they're taking their time with it. Again, even though they're reporting feeling much higher, a stronger effect. So it's really an interesting comparison. So going back to this question about high potency, what matters? So the concentration of THC in the product, who the person is, and also we know that how it's being used, right? So smoked versus oral is going to matter. We see different effects. And then we have the dabs versus, high potency cannabis. So we have cannabis flower that's being smoked, maybe vape cartridges that are being inhaled. But for every inhalation, there's only like so much THC that can be delivered at once. When you go to a dab, which can be almost 100% THC, what you end up having is people inhaling in one puff a lot more THC than they possibly could get from one puff of a smoked cannabis cigarette. Because the smoked cannabis cigarette it's not as efficient of a delivery system. So when we're thinking about high potency, we just had a paper accepted. Actually, it wasn't just accepted. It was accepted like 3 months ago. We're waiting for it to come out, but with American Journal of Psychiatry. And we looked at all of the literature to examine what are the effects of high potency cannabis. And the question that we asked there was not just putting a cutoff for what high potency is, but we said we want papers that are comparing. We want papers that are comparing lower potency, so 10% THC cannabis and lower, versus mid, so 10 to 15%, and then high, which is 15% to, whatever, 35%. And then also a comparison between smoked cannabis and high concentrate use. So we're looking at high potencies kind of with respect to comparing products, not just as a definitive cutoff. And we do that just because of the way the markets are set up. It's hard to definitively define what high potency is. And also when you say, okay, this is high potency and this isn't, it kind of takes away from, I think, the messaging that's really important to get across to people that at the end of the day, there's a dose-dependent relationship. The more you are exposed to, the higher the concentration, the greater magnitude of effect. There's not necessarily a cutoff. And also, it depends on who you are. Are you smoking every day? Are you using every day? Are you older? Are you an older person? Are you a younger person? Are you a man or a woman? We know that these individual characteristics play a significant role in what the health outcomes and acute effects are, as well as long-term effects. So complicated, it's a complicated question with a pretty long answer, but hopefully that's helpful in some respects. And I can share with you a little bit about how we're defining these things and how we're studying them with some of the funding that we have from the Department of Cannabis Control specifically, if that's helpful.
That would be great.
Yes, Laura, okay, good. That's helpful. Okay.
I'm here to
So,
learn. Please share
great.
all your knowledge
Okay,
with us.
so for the first one of the first studies that we are funded to do for the Department of Cannabis Control was this tax on high potency products.
Mhm.
Part of that project was to simply look at the literature and see, okay, well, if we're suggesting that high potency products should be taxed, well, why are we proposing that? And we're proposing that because we want to kind of nudge behavior to go to the lower potency products. And why are we doing that? Well, we're doing that because we hypothesize that the higher potency products are probably worse for health outcomes than the lower potency products, right? So that's an assumption. That's a hypothesis.
But
And so
I
we
will say
took,
that
yeah.
the market kind of defaults, and consumers are kind of defaulting to high potency being preferred. When if there was more evidence about the range of potency, or low potency can be good too, then maybe we wouldn't be defaulting to just these high potency products on the market.
So one question about that, Laura, is that are people defaulting and preferring the high potency products, or is that there just isn't the availability of
Mhm.
the low potency products? Because when we have people coming into our laboratory, and again, these are people in Los Angeles, most of the people that we see are daily, near daily users of cannabis. And we're giving them, our NIH government grade cannabis that every time I give a talk, somebody raises their hand and they're like, that stuff is crap. Why are you giving that to people? It's nothing like what's available. People don't like it. Laura, we have had people, at the end of study participation, we interview them and we ask them, they don't know what they've received. They don't know like the strengths that they've received. We ask them, okay, well, like, what do you think you got on this session? Was that high? Did that feel higher or lower? How does it kind of, how did it make you feel? And we've had people actually ask us where we get our cannabis from because they like it. Maybe in part they like it because they're not getting totally intoxicated off of one puff. It's like, they can smoke a good part of it and not feel, debilitated afterwards. But we're getting reports that people don't necessarily, do they like the 35% THC cannabis, and like why? Maybe some people like it because it's more efficient. You take one puff, you get the effect. Okay, well then you can go back to doing what you want to do. Right. But I think that, people use cannabis for all different types of reasons. Like, if you drink wine or a beer, you can imagine that, sipping that beverage over a period of time, if you're in a social situation, and it might be more conducive for that social situation than like if it's part of the social engagement than just taking one puff. But so there are some ideas there. And Laura, I totally forgot what the question was. The potency, right? So the question is for that study was, okay, what are the different models for taxing high potency products? And what is the feasibility? Can it be implemented? But the underlying assumption there is that, okay, if we want to nudge people's behavior to lower potency products, well, we want to establish that there's, what are the effects of these high potency products? So part of that grant was to do this deep dive into the literature. And I think we screened something like 4,000 articles for this study. It was an immense undertaking, again, because we were specifically we wanted papers, scientific studies that actually compared one strength to another strength, whether it's a population using one strength to a population that uses another strength, or if it's the same human being. We wanted to have that comparison there rather than just like asking people, okay, you use dabs, what happens? There, you don't have a good comparison. So we did this very large systematic review, and what we found, of course, was that higher strength cannabis concentrates versus smoked cannabis, you get a higher magnitude of effect. If you look over the long term, what we see is that people who are using higher potency cannabis products, concentrates, or higher strength cannabis, there is an association. So it's not a cause and effect, but it's an association between use of those products and risk for psychotic disorders, as well as developing problematic cannabis use, so cannabis use disorder. So for example, one study elegantly, tracked people over time and looked at how their behaviors at time point one impacted the outcomes at time point a year later. And what they found was that the people who were using the higher potency products 1 year later, they were using a lot more than they were a year ago. But the people that were using the lower potency products relative to the higher potency were not using more frequently. Now, there's a lot of reasons why that might happen. It might not just be the actual potency product, but it's an association, right? And so the impact is that the hypothesized impact is that if you start off using higher potency products, you have higher frequency use, sometime later, more problematic use, so on and so forth. And so we found hints of other mental health issues that were associated, again, not causing, but associated with those outcomes. But there are also, in doing that systematic review, we realized we know very little. Like, we need a lot more data on this topic, especially since, Laura, as you point out, you go into dispensaries in a lot of the legal states. And at the end of the day, this is what these are the options that consumers have. Some consumers can go for the lower potency products, but generally those are the CBD dominant, THC.
So maybe it's the manufacturers who is defaulting to the highest potency.
Maybe. And the question is why? Why?
Mm-hmm.
Right? And so, we could think of a lot of different reasons why. But, we're seeing that default. So this follow-up study, it's not really a follow-up study, but it's a study that I've been dying to do probably since like 2015. There was a paper, Jeffrey Raber, I don't know if he's on. Jeffrey Raber is a chemist, and organic chemist, and he got his PhD from USC, and he wrote a paper on dabs. And so it was 2015. It was a long time ago, well, almost 10 years ago. I cannot believe it. But we were just starting to learn about how people are using dabs, wax shatter. And around that time too, a woman named Mallory Laughlin, who's awesome. She was also in California for a while. She had done like the first survey of people who were using dabs. And if you think about it, for those of you in the audience who know about dabs, it is a very different thing than what we were thinking about cannabis was, for, a millennia, where you're rolling a joint. In some states, blunts are more popular, and you're smoking, plant matter. Maybe you're making it in brownies, whatever, back in the day. This is like you're taking the plant matter out of it. We're not talking about plants anymore. We're talking about pure, almost pure THC. And in those days, you had to use like a blowtorch or something like it to get it heated up. And I mean, it was totally different, a totally different thing, totally different vibe, right? And so I became really interested in it. And as somebody who studies drugs, I give them to people and I compare them to a placebo in the lab. I'm like, oh my gosh, we have to study this because this is going to increase in the population. We have no idea what the effects are. What we do know, though, based off Jeff Raber's paper, is that when people get one puff, they're getting a lot more THC than they get from smoking cannabis. Like, we have to study this. But of course, the issue was like, well, how am I going to study this in the lab? I need to find a federally compliant manufacturer of the product. I had to get approvals. I had to get funding. Oh my gosh, how am I going to get funding for this? How am I going to get through the FDA? Okay. And so in 2021, the Wall Street Journal came out with a report. I think it was May 21st, 2020, or May 18th, 2021. And finally, since 2016, the DEA had been sitting on all these applications that had been submitted from cannabis cultivators that were requesting to get their Schedule I license. Until then, only the farm in Mississippi, run through NIDA and NIH, was able to grow cannabis and manufacture it for research purposes. That's the cannabis I still use today. I love it. It's great. But they're not making dabs for me, okay? Like, that's a highly specialized product. And so I saw there were five producers that got licenses, and I knew one of them. And so I emailed him I texted him that day. I said, George, I'm like, we have to do this project where you guys can make me the dabs. We're going to compare a 50 milligram THC dab to a smoked cannabis cigarette that gives you 50 milligrams THC. And we just have to just compare the two. Again, the same dose, the same THC exposure, but how that exposure occurs, how much of it gets into the bloodstream at one time, just understanding that is really important. And so we started applying for grants, and it was hard because we hadn't, usually when you apply for grants to NIH, you need like some data to show that you can do this type of thing. But, we worked hard, we got some data, but we needed more. And so when the Department of Cannabis Control put out their RFP a couple years ago and said they were specifically interested in this, oh my gosh, it was amazing. And so we put in the application, and the application, even before we're looking at the effects in humans, we want to know what the difference is. If you have a dab, and I'm sorry, I'm going on and on about this. I'm going to stop in 2 minutes. But when you have a dab and a smoked cannabis, for example, they're both being inhaled, but the actual properties of the molecules are going to be different because you're heating up a dab to a very high degree. And the particle size is likely to be impacted. So, and what that means is that if you have smaller particle sizes, then the bioavailability or the ability to get into the bloodstream might also be impacted. So even before we're doing this study in humans, we collaborated with a group. They're called inhalation toxicologists. They are top notch. They're amazing at what they do. And they're actually looking to see when you light a cannabis cigarette, what do the THC particles look like compared to when you're lighting the dab? And they're also helping us to validate a rig. So when people use dabs, they use what's called a rig. This is the apparatus that people use to inhale dabs with. Nobody's ever done this in the literature before. So we just have to establish that we have a rig that is standardized, that is heating things up to a standard level. And so they're helping us construct this dab. So it's a really exciting project. Not only is it exciting from a pharmacological perspective, but also it's so needed from the public health perspective. So I'll pause there.
Well, thank you for nerding out on this so that we can have that precision of measurement to not just for consumer rights, for the consumers to know what they're taking and able to control how much they want to ingest and what they want to feel. But for the public health reasons, if we want to kind of move into the public health conversation, it's like taking a sip from a water fountain versus a fire hose, having a joint versus having the high heat of a dab. And maybe some people don't want that. We were talking about consumer preferences earlier. Some people, if they had a choice, might prefer lower dose, lower heat. Medical patients, maybe somebody has brain swelling, maybe they would benefit from a dab versus somebody who's just trying to handle chronic pain. So there's that spectrum of what consumers want, what their rights are in terms of product information and education. And I wanted to take you back to that New York Times article that came out maybe a few months ago or last month. And it was interviewing people who were feeling those symptoms and mental health issues from extreme cannabis use. Can you kind of summarize some of those clinical concerns and your thoughts on this?
So I apologize, Laura. There's been a couple of New York Times articles.
Oh, true.
So
it was the one where they interviewed people on their cannabis use and talked to the physicians that were treating them because they were had a plethora of chronic issues that came out of them using cannabis specifically.
Okay, so I think if it was the Megan Toohey one, I think that, and if I recall correctly, I think that a lot of it was focusing on cannabinoid hyperemesis syndrome.
Yes.
Right? And then also cannabis-induced psychosis, which is a DSM-5 diagnosed disorder. Those two, right? Mm-hmm. Those were the main things that were being focused on. And so cannabinoid hyperemesis syndrome, is something that I don't think 10 years ago any of us would have expected. And I think it's an example of the how much we don't know. And even though we can feel like we can predict what might be on the horizon, it's really hard to know because as you know, the chemical constituents of the cannabis plant, primarily delta-9 THC, is actually FDA approved to reduce nausea and vomiting in certain patient populations. And here we're starting to see, as of like 10 years ago, that people who are using cannabis, and again, we are not quite sure what are the underlying contributing factors are, but there is a group of people who have cannabinoid hyperemesis syndrome, which is extremely painful gastrointestinal distress that is coupled with extreme vomiting. Some people kind of liken it to cyclical vomiting syndrome, although they're very different. And so I don't think any of us would have thought that we would end up seeing this, just because that's not what we would expect from delta-9 THC. It's supposed to do the opposite. And so, there's growing recognition of CHS. If you talk to emergency room physicians in Colorado, Washington, D.C., or California, they will tell you every night somebody's coming in for CHS. And, there's no FDA-approved treatments, and it's hard to diagnose. And it's, patients report that using hot showers is helpful. Why that works, people haven't quite figured it out. So we have CHS, and it's gotten a lot of attention recently. I mean, I think I just got like an alert today on like Apple News that they had a whole article on it. It's getting a lot of attention. And then this other issue about cannabinoid-induced psychosis, or cannabis-induced psychosis. And that kind of dovetails along with a lot of the articles about the literature about the adverse effects of cannabis, for years has been related to the potential for cannabis to be associated with the development of psychotic-like disorders or psychosis. And, I think that physicians are starting to see more of this now. And so it's being highlighted more in the media. And people think that there is a link. So again, not cause and effect, but a link between using higher potency products and, cannabis-induced psychosis. And there's been some evidence in the literature also that if you look at different groups of people who are using different strengths of cannabis, you'll see increased risks associated with that higher use, higher potency use. So if I recall correctly, I think Megan Toohey was like focusing a lot on those two issues. I'm trying to think if she talked about suicide. I can't remember, but that's also an issue where, there hasn't been very strong data related to the association between cannabis use and a lot of other mental health disorders, but specifically we're starting to see more data come out about this association between cannabis use and suicidal ideation, also specifically in the younger population. We don't necessarily see as much out there about like cannabis use and associated with depression, but it's the suicidal ideation thing is starting to pop up more and more, which is concerning.
Well, and directly in contrast to the public perception that cannabis is low risk. So to now have evidence that it's extremely high risk for certain people, consumers need to know about that before it becomes a public health issue.
Right. And I do think, right. And so one thing that we're seeing, and we'll talk about the National Academy's report in a minute, but one of the features of the report was looking at, what have been the changes as a function of public policy in the United States. And so when you compare legalized states versus non-legalized states or jurisdictions, what you can see is that the risk perception of cannabis is reduced when legalization happens. Now, I will say, yes, there are risks associated with cannabis, and some of these risks are severe. Also depending on what the population is, who the human being is. But I also think that there's we're at a funny time not a funny time in history, but we're at an interesting time of history where when people talk about cannabis and the risks associated with cannabis, frequently they'll compare it to opioids, where, we know that right now, the market is being flooded with synthetic, very high, in the classical sense, pharmacological sense, very high potency opioids and we're I guess this year we did see a reduction in opioid fatalities, but this is a real issue, right? And so when you look at like cannabis compared to that, where people don't overdose from cannabis, people might think that this juxtaposition, oh, cannabis isn't so risky because people aren't overdosing from it. But there are definite risks associated with it that shouldn't necessarily be taken lightly, especially, in certain populations with certain family histories.
So what are some of the let's talk about the article, the National Academy of Science article. What are, and because it covered a lot, it was, maybe 200 pages or so. I was looking over the past couple of days. What do you think will be the most easily implemented policy? As we have a lot of states that have existing cannabis policy, and maybe they're open to making amendments. And as we look towards the future and federal reschedulization, hopefully deschedulization, what do you think are the easiest things that could be implemented in terms of policy that is considerate of public health and also social equity?
So it's a significant volume, and it was quite different. We had the National Academies had a report out in 2017 that was larger. I think it was 450 pages, and the goal of that report was to systematically review the health outcomes associated with cannabis and cannabinoid use. And one of those chapters was dedicated just to the therapeutic effects of cannabis and cannabinoids. Other ones were more adverse effects. This one was very different. It was describing what is the landscape of cannabis availability, the products that are available, what are the policies that have been implemented across the United States. Also, what are the policies, in other countries? What can we learn from them? And on a basic level, like, what is our surveillance like? So we're talking about cannabis and outcomes and how policy can impact those. Well, how do we measure that? How do we measure outcomes? Well, in order to measure the outcomes, we need to have surveillance. And when I talk about surveillance always sounds like a really scary word. It kind of creeps me out a little bit. But what we're talking about is we're, surveying the population to understand, what are the products available? How are people using them? How much are people paying for them? What are their preferences? What are their health outcomes? And right now, even though we have great national-based surveys, they don't get to the level of detail that is required in order for us to be able to make conclusions about how public policy is impacting health outcomes. And so, we can look at the report with respect to the recommendations that are in place there. And there's like 7 large recommendations there, like 7 buckets of recommendations. And so one of them, I'll share one or a couple of them. We're in the state of California, and the state of California, the Department of Cannabis Control, we have pretty high standards relative to the rest of the United States of quality testing and control. Okay. And so, like, is that enough? And so one of the recommendations here is that the agency, USP, United States Pharmacopoeia, which sets forth the standards for testing of all drugs, should also set forth standards for how cannabis and cannabis products should be tested. And states should be able to look to the USP for guidance and say, okay, well, the USP is putting this forth. So then in the state of California or in the other legal states, since we don't have like federal, regulation, states can look to the USP as guidance for how things should be tested. So that's one important step. Another really important point, and a lot of these recommendations were not just based off of state level, but also like federal, some type of oversight. We didn't talk much about, the loopholes that came into being with the 2018 Farm Bill that essentially legalized hemp, which is cannabis with less than 0.3% Delta-9 THC. And so when hemp became legalized in 2018, there were all types of ways for manufacturers to take that legal status of hemp and develop products that kind of go against the spirit, I think, of the Farm Bill, which is to not have intoxicating products. But we have lots of products that are proliferating the market in California, but also in states that do not have legal cannabis laws, regulation. And so one of the recommendations there is for Congress to really help to tighten up and define the definition of hemp to be able to protect the public from these types of emerging products that we know very little about and the public knows even less about. So those are two examples of some recommendations. And I know that we're kind of running out of time. I'm getting some alerts here, I think.
I think maybe we can take in a few questions from the audience,
Okay.
because all along people have been chiming in and asking for more detail. But I think you've just been giving us a really high level summary, and it's just inspired a lot of questions. So should we look into the chat, or do you want people to submit their questions, Joanna?
Oh, sorry. If everyone can put your questions right now into the chat feed, or I'm sorry, into the Q&A box with little question mark, and then we do have some in the chat as well. So, and I have some that have been messaged to me. So I'm just making sure I've got everything. So one of the questions is asking if there are any benefits associated with higher THC products.
So it's interesting. I think that when dabs came around, and this might still be the case. I remember one of my colleagues in the state of Colorado told me that when he was talking to some of his research participants, it became clear that some people did think that dabs was actually kind of a harm reduction approach, because essentially you're getting all the THC you need from like one inhalation, versus if you're smoking, you're exposing yourself to the combusted chemicals and toxins that are associated with smoking in general. So it seemed like there was a sense that maybe dabbing or using high potency products, it might help to reduce the respiratory risks associated with smoking. We do not have data on that. We definitely don't, but it's an interesting theory. Yeah, and it also speaks to, the fact that like when we're talking about cannabis and the way that it's used and who's using it and motivations behind use and the products that are being used, is that it's not black and white at all. We're talking about, there's a lot of different benefits, potentially a lot of different risks for respiratory, your respiratory organs versus your brain, right? So, we're thinking about how the delivery devices, it's not just a THC thing anymore. We're talking about lots of different chemicals and impact on your body, as well as, society and the community where this is all happening.
I actually love that you said that. And one of my questions that came to mind earlier was on the lung health impacts from smoking versus dabs. And, to what extent different versions of dabs have different effects. So whether it's a butane or a propane or hexane, distillate, solventless, rosin, and then also like the temperature that it's consumed and
But also a health risk is the hardware. Like
yes.
if we're heating up the hardware, it could be plastic or metal. Yes. Are we ingesting those additional toxins?
Little fine particles of heavy metals, and then also the purity of the extraction process, and to like if an extract is concentrating certain, let's say, pesticides or heavy metals in the soil that went into the cannabis plant, to what extent is that being that's being inhaled? So that's really fascinating, and I feel like deserves a whole other webinar just to talk about that alone.
Yeah, absolutely. Totally agree that the temperature, the hardware, things that I don't think necessarily are on people's minds when they're picking up their dab rig, right?
Let's see, any other questions from the chat? Oh, here's one in the Q&A. Are there equal or varying degrees of therapeutic effectiveness of different types of concentrates? Or again, is it more based on the individual consumer?
are there equal or comparable amounts of therapeutic effectiveness
in
for
different kinds of
concentrates?
concentrates. Because dab is
I
one
mean,
kind
like
of concentrate versus a wax or you know, something else in the liquid vape pens. Is there any evidence to the therapeutic benefits from any of those, or are we just still kind of looking at the extreme effects?
yeah, with therapeutic effects, there it hasn't really been looked at. The vape pen situation, although the vape pens have cartridges that are very high concentrations of THC. I put those like in a different bucket because the vape pens, you're getting a pretty small amount of THC for each puff. It's different than a dab where, you can have an 80% cartridge in a vape pen and an 80% THC dab, but it's very different with respect to how much THC the person is getting exposed to with like an inhalation. So I usually think of those as kind of different beasts. But with respect to the therapeutic effects of these products, we haven't looked at that. I think that in general, when you look at patient use behavior in some of these like large scale studies, it's a very small percent that are using dabs. The majority of the people are using either inhaled or oral administration. So I don't think that dabs are necessarily the product of choice for a lot of patient populations.
They're
But
very
there might be
expensive
a
too.
specific, they're very expensive. Yes.
Mhm.
Very expensive. If you actually like look at like how much each milligram of THC costs, across routes of administration, it might not be that expensive, but it's a lot of THC in a very small package versus let's say like a 5 milligram gummy, right? So which is like one dose versus if the dab is like 50 milligrams of THC, it's milligrams of THC per dollar is like an interesting conversation to have as well.
Mhm.
Yeah.
I was curious, are any of the physicians at UCLA prescribing cannabis to patients? Or are you just like seeing patients through through the clinical studies?
There's no infrastructure here at UCLA where physicians as part of UCLA Health are recommending cannabis, right? So you can't prescribe cannabis. You can make recommendations, you can
Mhm.
write a recommendation. So we don't have that here. Some physicians might outside of their work at UCLA Health, they might be doing that. But none here. But we do have, you know, physicians are starting to talk more and more with their patients about cannabis. What are some things to look out for? If they're thinking about, different types of products, things to keep in mind. What are some drug-drug interactions that should be kept in mind as well? So when you're dealing
Mhm.
with patient populations that are using drugs for therapeutic reasons, prescription drugs, you have to think about some of those drug-drug interactions, especially if they're using oral cannabis products. So clinicians, I think, are starting to become a little bit more comfortable having those conversations. But it definitely requires, uh, education and knowledge about some of these effects. But I think it is on more people's radar more and more as the years go by.
Mhm. And at least the data is now being openly collected in physician-patient conversations. No?
What do you mean by openly collected?
I thought you said in the beginning of the conversation that we could have been collecting this data since 1996, but only now are they
Right.
talking to
Well, no, I
patients.
mean, right. I mean, we could have been asking patients about it since 1996, but we just it hadn't been like implemented, right? So,
Hmm.
when you go see your doctor, they ask you, okay, are you smoking cigarettes? Are you drinking alcohol? Right. It's like, so there are
Now do
certain
they ask?
reasons
Now do
that
they ask?
now if you're like a primary care physician and you're going to see your primary care, I'm sorry, if you're a primary care patient, you're going to see your primary care physician before you visit, you will get a questionnaire about your use of cannabis, like how frequently you use, what types of products you're using for medical purposes. Um, so then that took a long time to implement. And it's not across all specialties, it's really just primary care right now. But it's important information. But I think, a lot of hospitals now will ask, oh, do you use cannabis? But they won't ask like follow-up questions. Like, if you're using like a topical CBD product, that's a very different thing than like if you're smoking a THC, or using THC dabs, but yet they're asking one question that can have the same answer from those two different people.
Mhm.
So our goal here, is to be able to get a more fine-grained, it's not even fine-grained, it's just like, it's basic information that's really important to understand the health outcomes. Yeah. Yeah, it looks like we have a lot of questions here. Anything, let's see. There's a lot of questions about the DAB study here. So to be clear, the DAB study isn't done yet. It's like in the works here. We got the funding. And so how we define the DAB and the DAB rig is going to be a very systematic, uniform way that will not necessarily generalize to how everybody who uses DABs is doing it, right? It's going to be just like all very controlled research. It's going to have parameters around what is the type of DAB we're looking at. And essentially it's THC, it's an extract, a THC extract. But it's, all that information would be in the publication. So it's not, other people can reference it and use it and can generalize as much as they like to what people are using from the DAB, the dabs that they're getting from their dispensaries. And our hope is that we're creating a model that does reflect what people are using. Yeah.
And maybe that's something that would inform the US pharmacopoeia as they try to standardize testing cannabis and cannabis products.
Right. Yes, exactly.
That's great. I'm so glad that you're pioneering this research because we can, it has to start somewhere. And in California, we've had decades to formalize some of these studies and the intake of data, and we haven't. And cannabis community and industry has changed so much from Prop 215 to 64. And I feel like that's some interesting information that like I wish we could gather, like tax data from the 90s. Like, we may have a plethora of data to go back and kind of study as it's more accessible now. Hopefully they'll remain funding for cannabis research, not just at the state level, but at the federal level.
Yeah.
We hope that
Yeah.
the incoming administration finds it important. Do you have any last words or any final points that you'd like to share with everybody? It's
That's
so
it. This
important to
was
translate the science into education, and many of us just could listen to this all day. But what's something that you really want to impart to folks?
I think that when we think about the effects of cannabis, it's always important to put on, the critical hat of understanding that cannabis is extraordinarily complex and people are really complex. And so, the high potency cannabis is a perfect example of how you can be talking about high potency cannabis, but be talking about very different THC levels of THC exposure or outcomes based on who the human being is, right? So I know that not everybody has a degree in pharmacology, but like thinking about, how are people taking it in? Who is the person? What else is the person exposed to? How much THC and other chemical constituents are people being exposed to? And you guys raised the excellent points about the hardware that's being used. When we think about the health risks, holistically thinking about all components are really important. And I think that's it. Cannabis is complex. We should have a center of cannabis complexity. There you go. But thank you so much for inviting me. It was really lovely to meet you, and I hope that we can meet in person at some point.
We would love that. Thank you so much for taking the time. Thank you. I've learned so much, and I think our audience has really benefited. We're going to be posting this on our website, so hopefully others can watch. And of course, we'll provide some links to your research so people can read the reports themselves. I just want to share a couple of upcoming CRC events. We're going to have another brown bag research conversation series in 2 weeks on Friday, December 6th with Dr. Robert Goldstein from UC Davis talking about his book called Can Legal Weed Win? And then we will be continuing this research conversation series in January, and it'll run through April. Every other Friday, we'll be posting that on our website and our link tree and our social media. So again, I just want to take a minute to sincerely thank you, Dr. Ziva Cooper, for being here and taking the time out of your day to share everything with our audience. And I hope that you will all have a great afternoon and weekend, and consider following our website, our social media, and signing up for our newsletter. We'll leave these links up here for a few minutes so you'll have time to register. And thank you, Laura, so much for taking the time as well to be here today.
It was my pleasure.
All right, thanks,
Thank you
everyone.
both so much. It was a pleasure. Have a wonderful weekend.
Yes, you too. Bye.